Hi, my name is Blair Winegar. I'm a neuroradiologist and head and neck imaging specialist from the University of Utah, and I'm going to be speaking on the introduction to orbital and CT and MR imaging. So I have no financial disclosures. I would like to thank CyberSight and Dr. June Kim for inviting me to give this lecture today. And so hopefully during this lecture, what I'm going to do is discuss some of the strengths and differences of CT and MRI for orbital imaging. We're going to define basic principles of image interpretation, and so you can get kind of the viewpoint of a radiologist in making diagnoses of orbital imaging. We're going to highlight essential orbital anatomy necessary for constructing appropriate differential diagnoses. And then the vast majority of this lecture will be showcasing CT and MR imaging of orbital disease conditions through case examples to show you how CT and MRI can be useful in helping with these diagnoses. So first off, talking about computed tomography or CT. This is a technique that uses ionizing radiation to create two-dimensional imaging of the body. And basically how it works is that you take X-rays in multiple different directions through the body, and then using some mathematics, you actually create basically a density map of your body. And so CT, the images basically just display the density of tissues. And it goes from black, which is less dense, so like air would be the least dense thing on the imaging, all the way to bone, which is typically going to be on the wider scale of the imaging, and then everything in between. And typically the centering value is for water. And so, for instance, in the globe, we can measure these densities with something called a Hounsfield unit. And so in the globe, it should be around 0, whereas anything less dense will be a negative value and anything more dense will be a positive value. And so CT is really great for many things because it's very fast, it's cost effective and widely available. And it's actually the best imaging for the osseous detail. And so it's kind of the first line choice for things like orbital trauma, where we are looking for fractures so we can see that osseous detail. But it also is pretty good for looking for things like infection or inflammation. The disadvantage, obviously, is that it has some radiation exposure. And so that could potentially cause a small increased risk of cancer. The other imaging modality we use in radiology is magnetic resonance imaging. And so this is a little bit more complicated, but basically we're utilizing high strength magnetic fields to align the spins of protons of hydrogen atoms in water. And then we put in some energy through radio frequency pulses to flip those protons. And as those protons come back to align with the magnetic field, they give off radio frequency waves that then are basically made into imaging. And so MR imaging is basically a display of water content and the magnetic relaxation times of tissues around it. And all of these different tissues, luckily for us, um, basically have different properties that allow us to see them as different. And so there's multiple different types of MR sequences that we perform. The most common are T1 and T2, which basically determine different spin characteristics as they go back to their normal positioning with the magnetic field and rotating in different ways. So the advantage of MRI over CT is that it has a superior soft tissue evaluation, which is really important in the orbit when we're looking at things that are fairly similar in density on CT, like the optic nerve, the globe margins. It gives you a little bit more of a higher contrast to these structures. The disadvantage with MRI is it's contraindicated with metallic foreign bodies in some medical devices because it's a high magnetic field. any kind of metal that is ferromagnetic could potentially be heated up or moved when you're put into an MRI scanner. The other thing is medical devices sometimes, run with electrical currents, and a high field magnet may produce uh, currents, or potentially destroy the device, or make it inoperable. So the other problem with magnetic resonance imaging is it's more expensive, and therefore less available. So one question I get asked a lot in radiology is when to use IV contrast when you're evaluating patients. And I think the top three things to when to use IV contrast for both CT and MRI is when you're suspecting an infection or an inflammatory process. Um, Secondly, when you're expecting a tumor or neoplasm. And third, when you're suspecting a vascular cause of the patient's issues. One time to not use IV contrast is actually during trauma, because if you give contrast, you may accidentally mistake contrast for blood, or vice versa. And so for trauma evaluation, I would suggest not doing contrast. But for these three indications, I would suggest giving IV contrast. And this is a case where a patient was in a trauma. This was 7 days after the trauma, had some facial trauma, and then it started to experience left eye swelling and irritation. And what had actually happened was this patient had an unknown carotid cavernous ICA aneurysm, which had then experienced a delayed rupture after the trauma and caused a carotid cavernous fistula. And so what you're seeing here, the yellow arrow showing the cavernous sinus, and that's having a convex lateral margin, which means that something's going on. It's just too big. And then the red arrow is showing the superior ophthalmic vein, which is also too big, has contrast within it. And that's because the contrast is shunting through the carotid artery into the cavernous sinus and then out the superior ophthalmic vein. And so this is one useful thing for contrast in this case. So going on to the basic principles of image interpretation. The first day of radiology, we kind of are taught, we get this discussion about the 4 Ds: detection, uh, describe, diagnosis, and decision. And so basically, when you're looking at an image, you have to be able to detect an abnormality to know that something's amiss on the images. Next, we need to be able to describe the image so that the clinician that's ordered the image is able to understand what we're talking about, where the abnormality is, what it looks like. And then using that information, we try to come up with a diagnosis, or at least a couple different diagnoses that this could be, so a differential diagnosis. And then finally, decision is what are we going to suggest to the clinician afterwards? For instance, if we see a mass on CT within the orbits, we may call the clinician, we may suggest doing an MRI to better characterize a lesion, or if we see something that's potentially dangerous, call the clinician and make them aware. The main thing when looking at images is knowledge of the anatomy, because it's critical to know knowledge for almost all of these steps. Um, if you know the anatomy, then you know what an image should look like, then it's easier to detect an abnormality. The anatomy is also important in describing where something is happening, and the extent of a disease process. And then for the diagnosis portion, knowing anatomy will help at least cone down that differential diagnosis. So if I know that a lesion is starting in the lacrimal gland, for instance, I know that the histopathologies that can happen in the lacrimal gland are vastly different from ones that happen in the optic nerve or the globe, for instance. And then finally, having knowledge of the imaging findings of associated medical conditions is what you need to know to be able to actually come down to a diagnosis. So knowing the specific imaging patterns of diagnoses is really the heart of radiology. So I'd like to first talk a little bit about orbital anatomy, and we'll just go through a couple like this one CT image and show you all the kind of subsites of the orbit that we look at. And so first is the orbital wall. So these are going to be bony, and so they're quite bright. And next is the preseptal soft tissues. So all of the soft tissues in front of the orbital septum. The globe obviously is right here. The optic nerve and sheath complex extends back from the globe towards the optic canal. The lacrimal gland is here in the lateral aspect of the anterior orbit. The extraocular muscles, so we're seeing the medial and lateral rectus on this image. The postseptal soft tissues, so anything behind the orbital septum, we kind of split these up into extraconal, so outside of the cone of the rectus muscles, intraconal, so within the cone of the rectus muscles, and then the orbital apex in the back where all of the important cranial nerves are coming into the orbit. So now we'll just go through some cases and talk about some findings that you may be able to make on imaging and how we go about looking at these. And so the first case is a 42-year-old female with left eye swelling, redness, and pain. We have an axial contrast enhanced CT image. And so my question for you is, what anatomic structure limits deep extension of skin infection into the orbit? Is it A, the annulus of Zinn? Is it B, the cornea? Is it C, the lacrimal gland? Or D, the orbital septum? All right, so 87% of you answered the orbital septum, which is correct. And so go on to the next slide. Orbital septum. And so the orbital septum is something that you can't is faintly visualized on imaging, but having a knowledge of what it is allows us to know kind of where it is on the imaging. And so basically it's a reflection of the periosteum off of the orbital rim that extends. Superiorly, it kind of comes together with the levator aponeurosis and then goes into the superior tarsal plate. And inferiorly, it just goes straight into the inferior tarsal plate. And this is like a fibrous barrier that doesn't allow any infection to go from the preseptal soft tissues back into the postseptal or orbital soft tissues. If you do high resolution MR imaging, you can actually see it quite nicely. These are kind of high resolution T1 weighted imaging. And you can see from these pictures from the literature, you see the orbital septum here kind of coming together with the levator aponeurosis and Mueller's muscle to go into the superior tarsal plate. And then this is just a coned in view of that coming together and going down towards the superior tarsus. I would say that in most cases, you don't actually see it on imaging. You just have to have a knowledge of where it could be so that you can decide whether or not a patient with an infection has, whether it's preseptal cellulitis or orbital cellulitis. And so this is a case of preseptal cellulitis, so an infection limited to the soft tissues anterior to the orbital septum. These are typically polymicrobial, and they're caused by direct inoculation of the skin or sometimes adjacent paranasal sinus disease. And so what we're seeing in this case is inflammatory thickening. You see that the preseptal soft tissues on the left are a little bit thicker. They have what we call inflammatory stranding, so the fat looks a little bit brighter than it does on the other side. And so you can see preseptal cellulitis also with abscess. And so this is a case of that where you have this abscess kind of along the temporal aspect of the preseptal soft tissues. And an abscess on CT, it's going to look like fluid density in the middle where the pus is, and then you have a rim of enhancement around it where your body is trying to wall this off. The red arrow in this case actually shows the orbital septum fairly nicely in this case. It's probably a little bit thickened because it's irritated. This is another preseptal cellulitis with abscess, but this one actually happened because of sinus disease. And so on the left-sided image, we're showing a T1 post-contrast FAT-SAT MR image. And on MRI, an abscess looks like it'll have low T1 signal intensity, and then adjacent enhancement. And then on CT, what we see is that that right frontal sinus is actually opacified, and there's a bony defect where this infection kind of tracked through and then got it sent into the preseptal soft tissues. Just to give you a little bit of a primer for what a T1 and a T2 sequence looks like. On T1, typically the fat is bright unless we do fat saturation, like in this case. And then on T2, actually both fat and fluid is bright. And so that's kind of the way that we can tell the difference. Um, in addition, you can do something called diffusion weighted imaging. And this is one example how diffusion weighted imaging is very helpful in infection. And that is where the abscess is, in the abscess cavity where the fluid and the pus is, you get diffusion restriction. So in this case, the trace image, the one on the left, it should be bright when you have diffusion restriction. So basically in the pus, these water molecules aren't able to diffuse normally because they're getting stuck in this kind of thick, purulent material. And then the right-sided image is what we call the ADC map. And so when you combine these two together and it's bright on trace and low on ADC map, we call that restricted diffusion. And again, abscesses restrict diffusion within them. So in comparison, orbital cellulitis is an infection of the orbital soft tissues posterior to the orbital septum. So either the intraconal and or extraconal soft tissues. These are often an extension of paranasal sinus disease. Since the orbit is so closely associated with the sinuses, you'll see a lot of disease processes go from either the orbit into the sinuses or more frequently from the sinuses into the orbit. And so this has the potential for serious complications, vision loss, abscess formation, cavernous sinus thrombosis, or intracranial extension of the infection. And so these patients are typically admitted for initial IV antibiotics and made sure that the infection is getting better before changing them to oral antibiotics. Whereas preseptal cellulitis is typically treated with just oral antibiotics. On MRI, we can see similar findings. Basically, going back to the CT, so what I'm showing here is that there's sinus disease within the left maxillary and ethmoid sinuses, so they're socked in with pus and mucosal thickening. And then in the left orbit, the yellow arrow is showing we kind of have this fat stranding where there's like these ill-defined little linear lines of inflammation extending through the fat. It looks a little bit brighter than it does if you compare it to the right orbit. You can see similar findings on MRI. This is that same patient after he's undergone sinus surgery, which is shown by the red arrow. The T1 pre-contrast image is actually very good for looking for inflammatory stranding. And so what I'm showing here is that the fat is going to be bright on a T1 weighted image, and all of those like kind of small linear lines of darker signal are actually inflammatory stranding. And then when we give contrast, we actually want to do fat saturation, and that will accentuate the contrast enhancement of this inflammatory stranding, as in this case. So case 1B, this is a 36-year-old male with left eye proptosis and pain. And so we have a coronal contrast enhanced CT image. And what we can see is a fluid collection in the superior orbit, denoted by the yellow arrow. So question 2 is, what anatomic structure confines this collection along the superior orbital wall? Is it the frontal sinus? Is it the levator palpebrae superioris muscle? Is it the periosteum or is it the superior rectus muscle? So 57% said periosteum, which is the correct answer. And so um, the periosteum is a fibrous layer that's along the margins of bones that serves a couple functions. One function is that when a bone is damaged, it actually can differentiate into osteoblasts to kind of heal that fracture or osteomyelitis or such. The other thing is it's a very thick fibrous barrier. And so in this case, what we're looking at is a subperiosteal abscess. It's basically an abscess confined between the orbital osseous wall and the periosteum. And these are also typically secondary to sinus infection. And most commonly, they happen from ethmoid sinusitis and frontal sinusitis, and seldomly we can see them with maxillary or sphenoid sinusitis. And these are more common in the pediatric population, but we do see them in adults sometimes. And so what this image is showing is that there's fluid or pus completely opacifying the left frontal sinus, and adjacent to it, you have this kind of lens-shaped rim-enhancing fluid collection along the adjacent superior orbital wall, and so that's a subperiosteal abscess. Here are a couple other imaging examples utilizing CT. The one on the left is showing ethmoid sinus disease with a medial subperiosteal abscess. And then the second image on the right is showing a maxillary sinus infection that caused a subperiosteal abscess along the orbital floor. But the basic premise is that um, you usually have this kind of lentiform or half lens shape where the base is going to be along the wall of the associated sinus disease, and then it gets confined by the periosteum so it doesn't go further into the orbit. This is different from what we call an orbital abscess, which is typically a complication of orbital cellulitis, where you have a rim-enhancing fluid collection, but it's not confined to that orbital wall. It's just within the orbit itself. And these typically require surgical drainage in addition to antibiotics. These oftentimes will present with severe symptoms or more severe symptoms than your uncomplicated orbital cellulitis, so more proptosis, ophthalmoplegia, increased eye pain with movements. And what we're looking for on the imaging is um, a rim-enhancing fluid collection within the postseptal soft tissues. This one kind of tracks along the globe, and you can see it's being pushed laterally. MRI is very helpful in kind of defining these abscesses and the adjacent structures to kind of try to keep the surgeon out of trouble. And so this is a case where you see this on the axial T1 post fat sat sequence, the rim enhancing fluid collection. It's kind of along the posterior and temporal margin of the right globe. You can see there's quite significant proptosis here. And then again, when we look on the diffusion imaging, we can see that when there's an organized abscess, the pus within the abscess gives you the diffusion restriction. So it will be bright on the trace. I didn't show the ADC map, but it was dark in this case. And finally, case 1C, this is a 38-year-old female with painful ophthalmoplegia. And so we have axial and coronal contrast enhanced CT images, and there's a little bit of asymmetry of a specific structure on the left-sided image. And so this is a case of cavernous sinus thrombosis. So on the left image, what you can see is I'm pointing out both superior ophthalmic veins. And the right superior ophthalmic vein does not have contrast opacification. And so this means that there's some potential clot within the vein if it's not contrast opacified. Whereas the left side, the blue arrow, is the normal contrast opacification of the vein. On the right image, what we're seeing is the red arrows are pointing to the cavernous sinuses, which are way too big. Typically, the cavernous sinuses are fairly thin, and the outer margin is either concave or straight, where these are very much convex. On top of that, the cavernous sinuses are venous sinusoids, and so they should be contrast opacified. Instead, there's these filling defects within them, and that's signifying the clot. And then finally, the purple arrow is showing sphenoid sinus disease. And so this patient had sphenoid sinusitis, which then went into the cavernous sinus and caused cavernous sinus thrombosis. So this is a life-threatening complication associated with infectious clot formation in the cavernous sinuses. It can cause a lot of symptoms, especially since there's a lot of cranial nerves, like cranial nerve 6 is within the cavernous sinus, and then cranial nerves 3, 4, V1, and V2 are kind of along the outer margin. And so any of these cranial nerves can be damaged or affected by cavernous sinus thrombosis. And it can affect both eyes because clot can extend. There are connections between both cavernous sinuses, so that clot can extend to the other side. And this is an axial T1 post contrast FATSAT image of another patient with cavernous sinus thrombosis, and you can see that there's this non-enhancing clot that's kind of enlarging the posterior margin of the cavernous sinus on the right. And so what we've just been talking about is called the Chandler classification. And so this is how we think about orbital infections and how to like assess the imaging for all of these different types of orbital infections so that we can speak the same language as you, the clinicians. And so basically it's a classification of orbital complications of rhinosinusitis. It's ordered in increasing severity, but not typically in order of progression. And what's nice about this classification is that um, if we're able to kind of define what the infection is, it is kind of basically all of the treatment for these is a little bit different. And so preseptal cellulitis, typically oral antibiotics, orbital cellulitis, IV antibiotics initially. Subperiosteal abscess is IV antibiotics plus or minus surgery, whether or not we can treat a smaller subperiosteal abscess and it goes away without surgery or not. And then orbital abscesses typically need surgery to be drained. And then finally, cavernous sinus thrombosis. Typically, you're going to do IV antibiotics and potentially some clot busting uh, medications, so anticoagulation. One additional case of orbital infection that's a little bit different than what we've previously described. So this is a 12-year-old male with acute lymphoblastic leukemia having left eye pain, swelling, and fever. And so we're showing an axial and coronal T1 post-contrast FATSAT sequence. And there's kind of a lot going on. There's a lot of inflammation. But the key finding here is this area that is not enhancing that should be. And so this is an acute invasive fungal rhinosinusitis. This is a very fulminant infection. And basically, my recommendation to you is if you suspect this, you should be getting an MRI and not just a CT. And the reason is because it has both diagnostic and prognostic implications. And the main imaging finding we're looking for this diagnosis is this lack of mucosal or soft tissue enhancement. So this is a large area of necrosis that's caused by the angioinvasion of fungi. And so if this patient was seen by ENT, they would look into the nose and see areas of black eschar, dead necrotic material. To treat these patients is threefold. You have to give them IV antifungal medications to treat the fungal infection. And then you want to surgically debride all of this necrotic tissue. So in this case, this patient underwent debridement of the sinuses, but also an orbital exenteration to get all of this necrotic tissue out of the eye. And then finally, to try to correct whatever immunocompromised state the patient was in to get this infection. And so it's a highly morbid condition associated with immunocompromised hosts. It's typically either poorly controlled diabetes mellitus or hematologic malignancies, but anything that can give you a low neutrophil count will kind of sap your body's ability to defend against fungi. So you can get orbital involvement from invasive fungal sinusitis. And the reason is just like with other bacterial infections, you have sinus infection, which then goes into the orbit. And so in this case, you can see a non-enhancement in that left nasal cavity, and the inflammatory changes within the left orbit are enhancing. And so the area of necrosis hasn't gone into the orbit, but the infection has. And so the right-sided case also shows a case of invasive fungal sinusitis where the area of non-enhancement is actually in kind of the lower nasal cavity and palate, but this infection also had tracked into the right orbit. You can see inflammatory stranding. There's kind of a rim of contrast going along the margins of the extraconal space there. And this is another case, an unfortunate case of a patient that had invasive fungal sinusitis. They had debrided the sinuses, and the patient was put on IV amphotericin, which caused an acute renal failure. So we don't have any contrast-enhanced imaging because we didn't want to damage the kidneys or the body any more than we had to. And what you can see is that there's like this subtle infiltration within the bilateral orbital apices. And unfortunately, one day this patient woke up with bilateral blindness. And so this is another and probably the most common use of diffusion-weighted imaging for us is that we can see infarcts or ischemic strokes with this MR sequence. And so what we're seeing is bright diffusion trace imaging going along basically the entire course of the intraorbital optic nerves. And so this patient had suffered posterior ischemic optic neuropathy or optic nerve infarcts to both optic nerves because of the angioinvasion of this infection. So we're going to change things up a little bit. Instead of talking about just the orbital soft tissues, we're going to talk about some things that affect the extraocular muscles. And so this is a 69-year-old female with proptosis. And so we have both axial and coronal CT images without contrast. And so the next question is, which extraocular muscle is the first involved in thyroid eye disease? Is it A, the inferior rectus, B, the lateral rectus, C, the medial rectus, D, the superior oblique muscle, or E, the superior rectus? So 51% said inferior rectus, which is correct, and I'll show why that is. So basically in thyroid eye disease, we get a couple different imaging abnormalities. One is thickening of the extraocular muscles, and typically it's going to be the muscle bellies that are thickened with sparing of the tendinous insertions. And so you can see where like these medial rectus muscles are coming into the globe. They're kind of normal in thickness, and then when you go more posteriorly, these medial rectus muscles are thickened. And in this case, you can see the inferior and medial rectus muscles are much more thickened than the rest of the extraocular muscles, and I'll explain why in a second. Um, where MRI is actually helpful in thyroid eye disease is when you suspect there's an acute inflammatory component going on. This is not the same case as the previous image, but what you can see is that on the T1 post-contrast image with fat saturation, there's just too much contrast enhancement in the retrobulbar soft tissues and in the extraocular muscles. And then we have a coronal stir sequence, which is basically kind of like a T2 fat saturation sequence that we use. And there's too much stranding. The extraocular muscles are thickened and too bright. And so all of these signs tell us that there's active inflammation. And these patients may benefit from a short course of steroids to decrease that inflammation. So thyroid eye disease is an autoimmune disorder involving the orbits and associated with autoimmune thyroid disease, typically Graves' disease. And the other finding that we can sometimes see is, aside from the extraocular muscle findings, we may just see a lot more fat within the orbits. And like the real way that we can tell that is if the extraocular muscles are not thickened and there's too much fat and there's proptosis in result to that. Um, but oftentimes the extraocular muscles are involved with inflammation or thickened because of these depositions with either collagen or glycosaminoglycans. And then the mnemonic that we use for the order of involvement is I'm slow. So typically it's the inferior rectus first, and then medial, then superior, then lateral rectus muscle, then the oblique muscles. And oftentimes it's going to be bilateral. It's oftentimes symmetric, although sometimes patients can have some asymmetry there. And this helps us differentiate thyroid eye disease from some other conditions that affect the extraocular muscles. So this is a companion case, a 30-year-old female with left eye pain, worse with movement. And so we have axial CT and coronal CT images. And this one's a little bit trickier than the last case, but what you can see is that the lateral rectus muscle on the left is too thick. And so this is a case of inflammatory myositis from nonspecific orbital inflammation or inflammatory, like orbital pseudotumor or idiopathic orbital inflammatory syndrome. There's a lot of names for this condition. But what's happened is there's a single infiltration of a muscle typically. You can have multiple muscles be involved, but most of the time it's one single muscle at a time. And this is another case of a patient just on MRI, and what you can see is again thickening of on this case the right lateral rectus muscle. It's enhancing. It's stir or T2 hyperintense, and so there's active inflammation happening within this muscle. These lesions can result in inflammation and involvement of the tendinous insertions. This one is a little bit thick at the tendinous insertion, but it's not super obvious. Um, and so that's how it differs from thyroid eye disease. This is the same case as the previous, but this was several months later. The patient was treated with steroids, did fine, and then came back again. And so this is a relapsing disease oftentimes where you can get inflammation in another extraocular muscle at a different time point. And so now the medial rectus muscle is involved, thickened, enhancing, T2 hyperintense. So we know that there's acute inflammation happening. So nonspecific orbital inflammation is a non-infectious inflammatory disorder of the orbits of unknown etiology and can affect multiple subsites. In this case, it's affecting the extraocular muscles, so we consider it myositis, but it can affect the lacrimal gland, the uvea, the optic nerve sheath, the orbital apex. And usually steroids are first-line treatment, but refractory cases may have to undergo chemotherapy, radiation, or surgery. So next we'll shift gears to lacrimal gland lesions. So this is a 59-year-old female with right proptosis and dull pain. And so I'm giving you an axial contrast enhanced CT image and a coronal T1 post-contrast image with FATSAT. And my question for you is, what is the most common lacrimal gland epithelial malignancy? Is it A, adenoid cystic carcinoma, B, lymphoma, C, mucoepidermoid carcinoma, or D, pleomorphic adenoma? So 45% of you got the correct answer, which is adenoid cystic carcinoma. And so adenoid cystic carcinoma, mucoepidermoid carcinoma, and pleomorphic adenoma are all epithelial lesions. Pleomorphic adenoma is actually a benign lesion that can become malignant, and mucoepidermoid carcinoma is just a little bit less common. Although lymphoma is probably the most common malignancy that affects the lacrimal gland, it's not an epithelial neoplasm. And so how can we tell in this case that we're dealing with an epithelial malignancy? So first off, you see that the lesion on the CT and the MRI is a bit heterogeneous. There's areas where it's not enhancing as much. There's actually a small dystrophic calcification within the lacrimal gland. And then that red arrow is showing the subtle area of osseous erosion of the lateral orbital wall, which can be associated with epithelial malignancies. On the right image on the MRI, one interesting finding is that we can still see a portion of the lacrimal gland that is unaffected. And so that usually signifies more of an epithelial lesion, because in lymphoma and then in inflammatory lesions, typically the entire gland will be involved. And so these are all findings that are suggestive of an epithelial lesion. And so adenoid cystic carcinoma, it's the most common epithelial malignancy in the lacrimal gland. This tumor has a very high propensity for perineural tumor spread, which we look at on imaging. We try to find any linear areas of thickening and enhancement which extend from the lesion along the expected course of nerves. And so these are typically, if it were happening in this area, branches of cranial nerve V1, which are extending back towards the superior orbital fissure. This case does not have that, but we look very closely because if a patient does have perineural tumor spread and that's not discussed in our report, then you may take out the tumor but leave tumor on these nerves, and so they will have a fast recurrence. About 20% of lacrimal gland masses are epithelial neoplasms. The most common benign neoplasm of this type is pleomorphic adenoma, which we had mentioned earlier. So this is a companion case of 48-year-old female with right painless proptosis, and I've got contrast-enhanced CT images, one with soft tissue windowing and the second with bone windowing, just to see if there's any osseous erosion. And this is a case of lymphoma. And so what we see in lymphoma is typically a mass that is homogeneous, so it looks the same throughout. It typically has some enhancement, although it doesn't enhance as much as like the mucosa does. And then it usually does not cause any osseous abnormality adjacent to it. On MRI, these lesions are very cellular, and the more cellular a lesion is, the more likely it is to have low T2 signal intensity, like in this case. And then you can see it's contrast enhancing, but maybe not as much as the nasal mucosa seen in the midline of the image. And this is another example of how diffusion weighted imaging on MRI is very helpful for us. So we've talked about how it's helpful for abscess and it's helpful for infarcts. It's also helpful in tumors to determine how much cellularity a tumor has. And that's because the more cellular a tumor is, and more with more nuclear to cytoplasmic ratio, the tumor cells are really packed in tightly and they don't allow water to diffuse between the cells. And so lymphoma is one type tumor that has a very high restricted diffusion, or what we consider a very low ADC map value. It's very dark on the ADC map. And so this helps us determine whether or not we're dealing with an inflammatory condition or lymphoma within the lacrimal gland. So most of these are non-Hodgkin lymphomas of B cell type. They can actually be bilateral at presentation, and they're typically treated with radiation therapy. And then finally, a 34-year-old female with left eye pain and proptosis. Again, a lacrimal gland lesion. But there are a couple different features to this one when we're thinking about it in comparison to the other images or other cases we've shown. So there's contrast enhancement within the lacrimal gland, but it kind of spills out into the preseptal and periorbital soft tissues. And there's kind of an increased stir signal and not decrease like we would expect for lymphoma. And this is Dacryoadenitis from nonspecific orbital inflammation. And so we're looking for areas like this case would also not show diffusion restriction. We're looking for inflammatory changes within the lacrimal gland and adjacent to it. And typically these patients will present with pain, whereas lymphoma is typically painless. Going on to ocular lesions. So this is a 75-year-old female with decreased left peripheral vision. So we have an axial T1 weighted image and T2 fat saturated image with a mass in the left globe. So what is the most common primary ocular malignancy in adults? Is it ocular metastasis? Is it primary vitreoretinal lymphoma? Is it retinoblastoma, or is it uveal melanoma? And the polls show uveal melanoma, 65%, which is the correct answer. Retinoblastoma is the most common ocular tumor in children. Ocular metastases could be more common depending on your patient population, but I asked which was the most common primary ocular malignancy, a little bit tricky there. Um, and so this is a case of uveal melanoma. The key feature here is that the mass is actually T1 hyperintense. There aren't that many mass or objects that are T1 hyperintense on MR imaging. Basically, there's melanin, which can be T1 hyperintense, protein, subacute hemorrhage, contrast, and that's why we give contrast for sequences, but this is non-contrast T1. Fat is bright on T1. And so this is a very good indicator that we're dealing with an ocular melanoma when we see a T1 hyperintense mass. It's typically dark on the T2 like we see in this case, and the red arrow is showing a subretinal effusion which has happened from this lesion. This particular case had on coronal imaging, you can see that the mass actually extended beyond the ocular wall for more than 5 millimeters. And so MRI was very helpful in this case in upstaging this tumor to a T5E tumor in the AJCC staging manual. And so not only can we kind of help diagnose a lesion, but we can help with staging tumors, and this was a case of that. So it's most commonly arises from the melanocytes within the choroid, but it can happen in the ciliary body or the iris, the other portions of the uvea. And these are typically going to have hematogenous metastasis and most commonly to the liver. And this is in comparison to like conjunctival melanoma, which typically has lymphatic spread, so to local lymph nodes. And so knowing this, doing a workup for metastatic disease, you want to typically look at the the abdomen would be the best thing to do. You also want to look at the lungs as well. So a companion case, this is an 88-year-old female with breast cancer evaluated for metastatic disease. And so this is a similar case, but what we're seeing here is ocular metastasis. And so these will typically not be T1 bright. They'll be kind of intermediate, but they will enhance. And what we're seeing again is a subretinal effusion from the ocular metastasis. And so these happen via hematogenous dissemination to the vascular choroid instead of the opposite with uveal melanoma. And most commonly, they're from breast cancer in females or lung cancer in males. Uh, this will be the last series of cases. This is a 48-year-old female with painless vision loss and papilledema on the left eye. And so this is question 6. Calcification is tracking along which structure in this image? Is it A, the ophthalmic artery? Is it B, the optic nerve? Is it C, the optic sheath? Or is it D, the superior ophthalmic vein? So optic sheath with 49%, that's absolutely correct. And so this is an indication of a optic nerve sheath meningioma. Meningiomas have a propensity to have dystrophic calcifications. And so on non-contrast CT imaging, we can oftentimes find these by just finding the calcifications. And so on the axial imaging, usually it tracks along both sides of the optic nerve sheath, and the optic nerve is in the middle, and we call that tram tracking, like the tracks of a train. And then on the coronal image, it usually encircles the optic nerve, and so we call that the donut sign in imaging. And this red arrow is just showing that these lesions typically compress the optic nerve sheath fluid, the CSF within the optic nerve sheath, and then that fluid gets kind of trapped anterior to the lesion and can cause papilledema, which we see as this kind of flattening or protrusion of the optic nerve head into the posterior globe. On MRI and on contrast enhanced CT, we see similar findings, this kind of tram tracking appearance of enhancement along the optic nerve sheath on the axial images, and then the donut sign or the encircling of the contrast on the coronal imaging. And so these are typically benign tumors of meningothelial origin arising from the optic nerve sheath. The optic nerve is very interesting because it's not really a peripheral nerve. It's an extension of the brain. It's a white matter tract that goes to the globe. And so anything that and the optic nerve sheath similarly is actually just an extension of dura or pachymeninges. And so anything that can happen in the pachymeninges, like meningiomas in the brain, can happen on the optic nerve sheath. And so these typically present with slowly progressive painless vision loss, and they're treated with stereotactic radiation to kind of decrease the amount of growth that these tumors have. This is a companion case of a 49-year-old female with right eye pain and partial vision loss. And what we're seeing is there's similarly enhancement along the optic nerve sheath. It's more infiltrative, so it has some like stranding adjacent to it, and so it looks more inflammatory. But this was a case of optic perineuritis from nonspecific orbital inflammation. And so obviously this will be painful and usually sudden onset, whereas meningiomas are usually painless and kind of a gradual onset of vision problems. And then this is another companion case, a 26-year-old male with right eye vision loss and pain with movement. And so these are contrast enhanced CT images, axial on the left and coronal on the right. And this is just an example. This patient could not undergo MRI, and so we tried to do CT. And you can see there's this very faint contrast enhancement affecting the right optic nerve. It basically goes from the optic nerve head, and it's throughout the intra-orbital segment of the optic nerve, but it's very subtle. And that's because on CT, the differences in attenuation between the regular optic nerve and contrast enhancement aren't that great. And so this is where MRI can be very, very helpful. And so these are some other examples of optic neuritis. We see this kind of short segment, posterior left intraorbital segment of the optic nerve, and then another ring enhancing lesion in the white matter of the left temporal lobe. So that was a case of multiple sclerosis, just like this. Typically in multiple sclerosis, if we have an active inflammation in the optic nerve, you're going to see T2 hyperintensity and contrast enhancement. And then we look for any other signs of multiple sclerosis in the brain, like this ring enhancing lesion, which denotes active inflammation or demyelination in this case. This is an example of neuromyelitis optica. This is from autoantibodies to aquaporin 4. And typically the optic neuritis in these cases is bilateral, and it typically affects the kind of posterior aspects of the optic nerve, optic nerves and optic chiasm, as we can see in this case. And then it will oftentimes have a longitudinally extensive transverse myelitis of the cervical spinal cord, which is also seen in this case. And then finally, MOGAD or myelin oligodendrocyte glycoprotein antibody-associated disease. These in adults will also tend to be bilateral, although they can sometimes be unilateral. And they're long segment optic neuritis and often with a perineuritis associated with them. And they typically go from the optic nerve head posteriorly and spare the optic chiasm, like in this case. And so one useful tip on MRI when we're trying to figure out if there's an optic neuritis on T2 weighted imaging is you can compare, since I said the optic nerves are a white matter tract, you can compare the optic nerve signal to the white matter within the brain, like up here. And so the optic nerve should be this dark. And so when they're bright like this, that signifies an optic neuritis. And that can be helpful in these kind of cases where both optic nerves are involved and you can't look at the symmetry or asymmetry between optic nerves. So in conclusion, knowledge of anatomy is critical for interpretation of orbital CT and MRI. CT is the first line imaging for evaluation of orbital infection, and so we showed multiple case examples of that. However, MRI offers superior soft tissue evaluation, and it's really critical in certain disease conditions like invasive fungal sinusitis and optic neuritis. And hopefully what I've shown is that CT and MRI are often complementary, and so they give us different clues to the pathology in the evaluation and diagnosis of orbital disease conditions. And having both, like especially for tumors, is actually quite good. Like the example I showed for adenoid cystic carcinoma in the lacrimal gland. I'm just going to go down through these questions and give the best answer that I can give. So the first question is, which imaging should we use for infiltrative optic neuropathy? And so optic neuropathy, I think I showed in that final case, is very much better to be evaluated with MRI than CT. And the reason is that on CT, you could tell in the one case I showed, which by the way, we thought was probably MOGAD just in one optic nerve. It just doesn't show the amount of tissue contrast that you need. And in fact, on that CT, that was read as normal initially until we looked back at it and saw that, yes, there indeed was some contrast enhancement in that optic nerve. And so I would suggest orbital MRI for those cases with contrast. Okay, next question is how to differentiate plane and contrast enhanced imaging on CT and MRI. So for the orbit, we have a saying called the nose knows. And so what we mean by that is look at the mucosa in the nasal cavity, and if it's contrast enhanced, if it's brighter, then that's when you're dealing with a contrast enhanced image. And typically on the orbits, on orbit CT and MRI, the nose is in the field of view, and so you can see that. And so that's how we tell if it's contrast or enhanced or not. The next question, which imaging should be the first line, or it varies with availability and type of suspected pathology? So it does vary with the clinical scenario. I think that with trauma, which I didn't really show any trauma because in trauma we typically almost always use CT, and so MRI doesn't really play much of a role. There's a couple niche things that you can do with MRI, like look for orbital foreign bodies that are not dense on CT, stuff like that. But usually you want to do CT without contrast for trauma. Um, I would say that we typically do CT first for infection or inflammation. MRI can be very helpful in, especially when the infection has gone beyond the orbit and sinuses into the brain or, into the intracranial compartment. And so that's when we really want to use MRI. Um, and like I said, I think MRI is so useful in acute invasive fungal sinusitis. And like on CT, that area of non-enhancement is not that easily seen. And so MRI is really great in showing the extent of the necrosis that's happening. And it has some prognostic indications that if that non-enhancement's going into the skull base, for instance, that's a poor prognostic indicator. And so MRI for that scenario is much better. Um, so hopefully that answers that question. The next question is, what does the optimal imaging order look like from your perspective so that you can do your job most easily and effectively? So I think that uh, so typically for infection, those patients are first seen in the ED, and doing a CT is the quickest way of getting the answer. And so CT for orbital infection and inflammation is the answer, and then doing MRI to look for any complications of the infection is sometimes necessary, but we can do that if we are suspecting something. It's a little bit trickier with orbital tumors. I think that MRI has more utility than CT in orbital tumors. Like I showed, I think like for the lacrimal gland tumors, for instance, seeing the fact that like the full gland is involved or not is super helpful, and it's easier to see on MRI. In addition, having that the diffusion weighted imaging is really helpful in kind of telling us whether how cellular a tumor is. I didn't show a case of pleomorphic adenoma, but those cases are typically really T2 bright. They enhance, but they'll have a very high ADC map value. And so we can say with certainty that it's a benign tumor, whereas lymphoma is usually very, very dark, and we can kind of nail that diagnosis. And why is that important? I think if it's a pleomorphic adenoma, you don't want to just take a piece of that, or else it can spill into the surgical cavity, and then you have, instead of having one pleomorphic adenoma, now you have a ton of them, and then it's more likely for them to undergo or there's a higher probability that one of them will turn into a carcinoma ex pleomorphic adenoma. So that's one very useful thing that we can do before biopsy is say, hey, this looks like a lymphoma. You just need to take a piece, and then we'll treat it with radiation instead of taking the whole lacrimal gland out. Or two, you have this lesion that looks like a pleomorphic adenoma. You need to take it out in bulk without disrupting the tumor capsule. And so that's where something can be very useful. Um, okay. a patient complains when she bends forward and her eyes come out like proptosis, no history of trauma or thyroid. What can be the reason? And I agree with that statement, orbital varices. And so orbital varices, we can try to diagnose them on CT and MRI. And what we typically do is we give contrast enhancement and we image before and after provocative maneuvers. So we can, like if the patient, if this proptosis happens with Valsalva maneuver, for instance, we can do imaging without Valsalva and then make the patient do Valsalva and then image again. And we can do it with either CT or MRI. And then with Valsalva, these varices usually blow up and we can see them quite nicely. We have a couple cases of that at my institution. And so I agree with that statement. Another thing that could potentially do this is a cephaloceal. And so that being a herniation of brain and or meninges that go through the anterior skull base of the orbital roof into the orbit. And you can use either CT or MRI to kind of diagnose that. Usually on CT, you'll see a soft tissue defect and a little bit of protrusion of the brain. And then MRI will show the same thing. So that's another potential etiology of that. That would usually be just unilateral, though. Do you recommend CT and MRI simultaneously? That's a good question. I think we usually don't. And so we do them stepwise. And that's because, we never know what we're going to see beforehand. Even with, imaging is kind of like you have some pretest probability from the patient's symptoms of what you expect is going to be happening. And so um, basically, in an ideal world, we have this pre-test probability, and then we can determine whether or not CT or MRI is the best thing to do. Oftentimes, if a patient's being seen in the ER, it's like much easier to get a CT than an MRI oftentimes, and so we'll go with that, and then we'll suggest an MRI if we see something on the CT that needs that. Even though sometimes an MRI would be the better first choice for diagnosis. That being said, if a patient has suspected like optic neuritis, we're not going to bother with CT. And I just showed that one case to show you why it's so challenging to make that diagnosis on CT. And so basically on the clinical scenario is what we try to determine which one to go with first. And then if we need the other one, then usually we'll suggest that. And so kind of a similar question as a general rule, what determines the type of imaging modality to request? Secondly, is it possible to request both an MRI and CT for the same disease? And I think the answer is yes. And the reason to do both is kind of if we think that CT would give us some additional information if we already have the MRI or vice versa. And so um, it's a little bit tricky. I would say for infection, um, do CT first with contrast. And then, usually we determine whether or not um, there's some use for MRI, whether or not we think there might be a subdural empyema, whether or not we're trying to define whether this area of non-enhancement is a phlegmon versus an abscess that has to be drained. And so one other scenario that sometimes comes up is maybe they'll get an MRI first for an orbital infection. And then we find something like, let's say, a subperiosteal abscess. And then the patient needs to go to surgery and have their sinuses cleared out. Oftentimes the sinus surgeons like to have a CT that they can plug into their stereotactic software so that they know where they are when they're doing the surgery. And so they will request a CT in that scenario where it's not much about looking at the CT and giving more additional findings. It's more about them just having the software to use for their surgery. So that scenario comes up every once in a while. Um, but you can potentially request CT and MRI at the same time. Um, but then again, like we might be able to make the diagnosis on just one or the other. Um, okay. Can MRI be a valuable tool in glaucoma? So, this is a little bit tricky. I think one scenario that it's helpful in is trying to determine whether or not there's been damage to the optic nerve. And so typically we would look at it on MRI and see if the optic nerve thickness, it looks smaller than normal, if it has more fluid within the optic nerve sheath. It's a little bit tricky. Like I think the imaging findings for glaucoma aren't super reliable on CT and MRI. And so really, the one scenario that I can think of off the top of my head is whether or not there's been some, uh, you know, damage to the optic nerve. And there's other ways that you can look at that. I'm pretty sure. Um, okay. So next we have a question. What imaging study is most specific for carotid cavernous fistula? So, in my opinion, the best imaging for it is an MR angiogram. And the reason is I didn't show any cases of this. But an MR angiogram basically utilizes a sequence where we're actually seeing flow within the arteries. And it's not just contrast opacification of them, it's actually showing that there is moving blood within the arteries. Um, and so what's useful about that is that if if that flow goes from the artery to the vein, it should never do that. And so when we see that, we're confident that there's a carotid cavernous fistula. Um, that being said, sometimes so there's two different types of carotid cavernous fistulas. One is a direct, so like in the case I had where an aneurysm ruptures into the cavernous sinus, there's actually a high amount of flow going through that, and so it's easier to see on imaging. There's also ones called indirect, where you have feeders from either the ICA or ECA or both that go into the cavernous sinus, and then like a small little artery has ruptured and there's less flow related signal. In those scenarios, it's a little bit trickier to diagnose with cross-sectional imaging, and you may need to do an angiogram to fully characterize it. And so if there's a high suspicion and we're not seeing it on imaging, then maybe going to an actual diagnostic catheter angiogram would be the best choice. How to differentiate Coates disease with retinoblastoma through imaging. Um, I don't do a lot of peds anymore, but retinoblastoma, typically you're going to have an actual mass on the globe. And we used to do CT imaging for this to look for these calcifications. We don't do that anymore because the retinoblastoma gene is actually a DNA repair enzyme abnormality. And so we want to reduce the amount of radiation we're giving to these patients because of the potential for causing another cancer. And so typically we do MRI now. And so retinoblastoma will typically look like a mass. Depending on when you catch it, it can be small, it can be big. And then Coates disease is like typically what you're getting is like subretinal effusions. And so they look quite different. I didn't talk about this in my presentation, but usually a retinal detachment or subretinal effusion has like kind of a V-shaped, and you can get that in the case of retinoblastoma, but typically you'll see a mass with the subretinal effusion, whereas in Coates disease you may not see the mass, and typically the globe's a little bit smaller. So that's how we tell the difference. And then what's the difference between T2 fat sat and STIR, and how does that help us? So um, there are several ways that we can do fat saturation, and they're based on different like properties for MRI. Fat sat, what we're doing is it's called chemical saturation, and so we're utilizing the fact that fat actually has a different precession frequency than other soft tissues, and we can use that in our advantage to send in a pulse that kind of suppresses that precession frequency. STIR stands for short tau inversion recovery, and so in an inversion recovery sequence, we start the pulse sequence and then we send in a pulse in the middle to reverse the signal from a certain kind of area of the signal. And so in short tau inversion recovery is not exactly a fat saturation sequence, but a T1 suppression sequence. And so anything with T1 hyperintensity of that, like similar to fat, will be suppressed. The reason why STIR is better than T2 fat sat oftentimes in the orbit is that we get something called susceptibility artifact, which is like the magnetic field doesn't really like areas like air or bone, and so it like the field gets distorted. And in orbital imaging, since like the specifically the inferior orbit is so close to the maxillary sinus and that susceptibility, that you may get a loss of fat saturation if you do the chemical saturation type, the T2 fat sat. And so it'll look brighter. It won't completely suppress the fat on the inferior margins of the orbits. And so STIR is a little bit more robust in that. And so it gives you a more homogeneous fat suppression. And so we typically do the coronals as a STIR instead of a T2 fat sat for that reason. Which broad categories of cases does T1 imaging is useful versus T2, and when to order fat suppression? So our typical protocol is to do axial and coronal T1, T2 fat saturation, or a STIR for the coronal images, and then T1 post contrast with fat suppression. And the reason is anytime we can kind of improve the contrast of abnormality versus not abnormality is what we're going to do. So in T1 weighted imaging, it's very good for anatomy. And really, we don't want to use fat saturation in that, because if we see something in the fat is going to be bright, and usually something else is going to be dark. And so we can see the difference there. When we give contrast enhancement, we want to fat suppress because we want to see the difference between the dark fat and the bright, abnormality. And so that's why we do it in that way. In I mentioned before, in regular T2 images, the fat is bright. And so when we're looking for edema, which is also T2 bright, then we have bright on bright. And so it's hard to see the difference between the two. And so that's why we do suppression on T2 and T1 post-contrast imaging. It does add a little bit of time. And so some people will do T1 pre and T1 post, and you have like a direct comparison. But it's harder to see the abnormalities on the T1 post without that suppression. Um, okay, indication for MRI and thyroid eye disease in pediatric patients. So the real reasons to do MRI and thyroid eye disease are basically one, like I had mentioned, acute inflammation. That will tell you whether or not you should probably give steroids to decrease that inflammation in the short term. Another reason for MRI is it's a little bit better at determining whether or not the optic nerve is at risk from being compressed. So the thickening of the muscles can extend towards the orbital apex, and when they get really thick, those muscles kind of can encroach upon the optic nerve and may need to be decompressed. Um, so that's another reason, and then you can look at the optic nerves themselves to see if there's any signal abnormality or thinning, and that would be indicative of a compression abnormality of the optic nerves. And so those are the two main things that I can think of that MRI is really helpful in thyroid eye disease, and that would be for both adults and pediatric patients. Plus, you have the benefit of not giving a child a radiation dose, and so typically, in the children's hospital that's across the street from us, they're going to err towards doing an MRI over CT. Especially radiation can induce cataracts, aside from potential risk of causing a cancer. So that would be why to use MRI. Next question. What is white-eyed blowout fracture? Why does it need an immediate intervention in pediatrics? So it looks like there's been an answer to that in the question. So I know of these as what we call a trapdoor fracture. So basically the idea is that you have a fracture, and so usually an orbital blowout will push the floor down. In occasions, especially in pediatric patients where the bones are more pliable, you can have herniation of extraocular muscles or orbital fat into that defect, and then the fracture, once it's fractured and the pressure goes back to normal, it will shoot back up, and it's kind of like the trap door of a stage. So it's kind of entrapped the orbital fat and or extraocular muscles below the orbital fracture. And why it's important is just like it said in here, is the oculocardiac reflex, which is a reflex that can cause bradycardia, potentially a cardiac arrest from extraocular muscle movement. So um, that would be why it's important to get the intervention sooner rather than later. Next, what exactly do you see when there is choroid invasion and optic nerve invasion in cases of intraocular tumors? So, basically, this is better seen on MRI, but even MRI is not perfect for this. But when we have cases of ocular melanoma and they're very close to the optic nerve head, we try to see if there's any area of the enhancing tumor or that T1 hyperintensity of the tumor extending into the optic nerve head. And choroid invasion, I mean, these tumors like are starting in the choroid, so that's already invaded. But sometimes we see when it breaks through Bruch's membrane, they kind of take on a kind of mushroom shape. Um, uh, and so that's also indicative of I guess uveal or choroid melanoma when it has like a shape that looks kind of like a mushroom. I haven't seen many cases that look like that. But basically what we're trying to do is determine the extent, the size of the tumor, whether or not it's going beyond the ocular wall, whether or not it's going into the optic nerve. And so what we're looking for is just, does the tumor look like it's in spots where it shouldn't be? And so what an intraocular optic nerve invasion would look like is it kind of tracking into the optic nerve, so like there'd be enhancement or whatever. Um, so it looks like uh we're getting close to time, so maybe I'll answer just one more question uh and then I can answer the rest online, so or offline. Uh I'll answer this one. Is there any standard left-right side direction for orbital, sagittal, and coronal imaging? Um, so basically the orientation for CT is such that if you were a surgeon looking down at a patient, and so uh the axial images, the basically the right side of the patient is on the left side of the image. And so that's going to be the same for both axial and coronal images. If you think about it, like if you were on overlooking a patient, the left side is going to be the right side of the image. That's how we kind of do it. And typically on sagittal images for CT, we have the face facing the left side of the screen. Um, and that's just by convention, but uh, usually in plain films it's the opposite. So um, anyways, well, I guess we'll stop there and I'll try to answer some of these other questions offline. I just want to thank everybody for attending the session. This is super fun for me. I love orbital imaging, and so getting to share this information with you has been super fun. I would like to just thank a couple other people. Dr. Jun Kim, who's one of my clinical colleagues here at University of Utah in the Moran Eye Center, for inviting me to give this talk. Bundit Tanawankosi was one of my mentors in residency and a head and neck enthusiast, and really loved orbital imaging and inspired me to like this subject. And then several of my colleagues and mentors during my fellowship, Rick Wiggins, Yoshimi Anzai, Rick Harnsberger, Karen Salzman, and Edward Quigley, for giving me case examples and encouraging me. And yeah, so with that, thank you.